Hello, thank you community, and welcome to today's webinar, Adherence and the Role for New Technology. Thank you for joining us today. I'm Joe Cincioni, a Senior Managed Markets Liaison for Otsuka Pharmaceutical Development and Commercialization, Incorporated. I'll be serving as the moderator and presenter for today's exciting discussion featuring Drs. Velligan and Craig Chepke. So now I'm going to turn it over to Dr. Velligan to discuss medication adherence in mental illness.
Thank you so much. I so appreciate being here, talking about one of the things that I think is so important, medication adherence for people with mental illness. We're going to talk a little bit about what adherence looks like and what are the consequences of adherence, and then what are the reasons that people don't take their medicines, and I'll talk a little bit about what we can do about it. Adherence is really the extent to which a person's behavior corresponds to what they've negotiated with their healthcare provider. So in a shared decision-making kind of framework, people come to an agreement about what they're going to take, and adherence is how much their behavior relates to that. We know that problem adherence is a big deal because there are a lot of serious consequences for people with mental illness. So for people with schizophrenia, if you're not taking your medicine regularly, the risks are hospitalization, chance of violence, and higher mortality rates. For people with affective disorders like depression and bipolar disorder, there's a risk for suicide, for hospitalization, and there's also a risk that you're not going to get better as quickly. So you're going to have a slower initial recovery from the illness. And then, of course, for substance abuse, there's issues about increasing in substance use for people with opioid use disorders and treatment dropout and also mortality. So we're talking about big risks for the individual. There are also risks for society. Hospitalizations are very expensive, and it's estimated that the cost of hospitalization related to non-adherence in the US every year is around $1.5 billion. So we're talking about a huge public health issue when we're talking about problem adherence to medication. So this slide shows the estimated prevalence of medication non-adherence across different psychiatric disorders. And what you'll notice is that only about half of the people are really taking their medication. That's on a good day. And non-adherence rates in opioid use disorders are about 68%. So we're talking about a lot of people not taking their medication. And, you know, when we think about our own patients, a lot of times we don't realize that 1 out of every 2 people that are walking through our door really aren't taking their medication as prescribed. And this is true across the board for depression, bipolar disorder, schizophrenia, anxiety disorders, substance use disorders. It's also true for medical conditions that none of us are really that good at taking our medication. So why is this? There are multiple factors that determine whether people are going to be good at taking medication or are going to follow through with medication recommendations. So there are factors that are related to the treatment specifically. Is it effective? If I don't think this medicine is working, I'm not really going to take it. And part of the issue is that we can't overpromise. If we tell people this medication is going to get rid of your depression or your voices, and it doesn't completely get rid of those, people might have too high of expectations and might decide that the medicine isn't effective. There are also side effects. Some are more tolerable to people than others. There's also fear of side effects. There's past medication experience, and there's how often do you have to take this medication? How inconvenient is it? So there are also patient-related factors. People have a lot of stigma associated with mental illness, and they don't want to be considered mentally ill. They're afraid of the potential side effects. They might even think medicine is not needed. And so that gets us into disease-related factors like poor insight. Some people don't realize, especially if they're in a psychotic episode or a manic episode, that they really need help. There are a lot of cognitive impairments as well, and comorbid conditions, including substance abuse and medical problems. Then there are a bunch of social and economical factors. So there are people who don't have a daily routine. They don't get up at the same time every day to take a shower and go to work. So there's no routine to tie taking medication with, and so they can't take medication regularly. It's not easy for them. There are also people that have financial constraints. They're not able to pay a copay or have enough gasoline to get to a pharmacy. There is a lack of education, sometimes a lower level of literacy. Caregivers sometimes aren't there to supervise people. I go to boarding care homes often, and they tell me, well, if people don't come to the line, I can't go hunt them down to give them their medication. And as a provider, we often assume that if people are in a living environment like a boarding home or a care home, that they're getting their medicine, and they may not be. There are also healthcare system problems. There is trouble sometimes discharge planning. People fall through the cracks in between the hospital and the outpatient clinic. And sometimes people just have not the resources they need to follow through. So there are a lot of factors that influence non-adherence. What can we do about it? That's really the next slide. So if we look at the reasons for non-adherence, then we can tailor our interventions so that they'll work better. So for someone with lack of insight, you might give them all the reminders in the world they're not going to take their medicine. You need to address their lack of insight with some motivational interviewing, some focus on the family to help the family to understand why taking medication is so important so that they'll support the decision, and some psychoeducation, and maybe longer visits and more frequent visits to develop that kind of rapport and that shared decision-making approach that can help people make a good decision. There are also, if people have persistent symptoms, medication can't do everything. So maybe some cognitive behavioral therapy to help people with persistent voices or persistent depression, that can be very helpful. For substance use, people may need to have integrated dual diagnosis treatment. If there are logistical problems, you need social work or case managers to go and help people to figure this out. How can we get the medicine to you? How can we remind you to take it? How can we get you to your doctor's appointments? Lack of routines are important. People don't have anything to tie taking regular medication to if they don't have somewhere they go every day. So it's important to establish routines for them, and social workers and case managers can help with that. And there's also interpersonal social rhythm therapy for people with bipolar disorder so that they get in these routines of taking medicine and taking care of themselves holistically. Cognitive impairments are important, and those can be sometimes bypassed with some of the environmental supports that we can use, pill containers and alarms. There's also social work for those kinds of logistical problems. If there isn't a good therapeutic alliance, it's really important to tie taking medication to the person's recovery goals. A recovery goal is never, gee, I want to take medicine. A recovery goal is what the person wants to do, take better care of their animals or sleep better. And often you can build an alliance around those things so that people are going to be more comfortable with your recommendations. And finally, a lot of times people don't have the family or social support that they need to take medication, and peer counselors can be very helpful for this. Social workers or case managers and the family can be educated to help, to support people. So if we can tailor adherence interventions to the person, there's a better likelihood that we're going to get success.
Okay, very informative. We do have a few discussion questions here. So, Dr. Velligan, how do factors influencing non-adherence vary by type of mental illness?
Well, you know, adherence problems are true across the board, but there are some differences. So somebody, for example, with schizophrenia who has negative symptoms, or somebody who's severely depressed, are going to have motivational problems that impact whether or not they're going to take adherence. So I have people that tell me, you know, Dr. Velligan, I was supposed to take that medicine, but I was already in bed and it was all the way over in the kitchen. So there are sometimes motivational problems that interfere. Sometimes people might not have insight into their illness. So someone might think, well, I'm not that depressed, even though they're staying in bed all day, every day. Or someone with schizophrenia or in a manic episode might not realize that they need help. And then certainly with some of the opioid use disorders, some of the medications might have street value. And so there are differences depending on the illness. And again, we want to tailor our interventions.
One thing I'd jump in there, this is Craig Chepke, everybody, hi. So another diagnosis that was mentioned was something like generalized anxiety disorder. Many of my patients with very strong anxiety are terrified of side effects, and I'll often start a medication for them at a lower dose, maybe a much lower dose than the same medication I might use in major depressive disorder or another diagnosis.
I think that's a great point. Yeah, if you're terrified of the medication, you've got to go really slow, and they have to trust you.
Exactly. So we do have a second question here. What are some similarities and differences in the recommended treatment approaches for mental illness? Send this over to you, Dr. Velligan.
So I think that there are a lot of things you can do across the board. Like you can make the treatment regimens much more simple for people to follow. You can, for people that are having trouble doing things regularly, you can set up alarms or text reminders. There are things you can do across the board for a lot of people, but there are also some specialized treatments. So for example, long-acting injection for people who have schizophrenia for antipsychotic medicine can help you to know when adherence starts. It can help you to differentiate between problem adherence and lack of efficacy of the compound you're using. So that's one example. And I'm sure, Craig, you have other examples.
Yeah, absolutely. So, the first point you made about making the regimen simpler, I think is a really important one. So being savvy when we prescribe. One example could be that if we have a patient who's on an antidepressant that is neither sedating nor causes them any activation or insomnia, but they are also taking a hypnotic medication for insomnia, I will always tell them, take both of them at night instead of taking the antidepressant in the morning and the hypnotic agent at night, because people are more likely to remember once a day pills versus twice a day. And then also, if there's extended release formulations of meds that you can give instead of a multiple time a day regimen, moving to an extended release form that's once a day, that is also can be crucial. And certain things that have been shown throughout some research, for instance, lithium dosing in bipolar disorder has been shown in several studies to be non-inferior when dosed all at bedtime, as opposed to twice daily dosing or more for most patients, not for everyone, of course. But anytime we can think early on in the treatment regimen in terms of prevention of how can I prevent this from getting too complicated for my patient, that's, I think, a better approach than trying to figure it out post hoc and making adjustments.
I think those are excellent points. And we use a lot of supports. We use pill containers and signs and alarms that can help a lot of people to take medication. So I think there are a lot of ways to deal with this.